Hello, my name is Nathan, and I'm going to do my case study on spondylolysis. The exam for a lumbar spine is the AP lumbar, both obliques of the lumbar, lateral lumbar, and L5S1, and a flexion and extension projection is optional. The patient was a 14-year-old patient that presented with extreme lower back pain, resulting in numbness and tingling down her thighs and legs. The patient also had difficulty standing for long periods of time due to the severity. Our technical and patient considerations consist of SID of 40 inches for all projections. Our field size will be 14 by 17 in a portrait. And we'll start with the AP projection. The KV will be at 80 to 85. Our mass will be set at 32, and we'll center at the level of the iliac crest. For our oblique, KVP will be at 80 to 85, mass at 32 to 40, and we're going to center at L3, or the lower level of the costal margin, 1 to 2 inches above iliac crest and 2 inches medial to upside ASIS. Then we will go to the lateral, and this includes flexion and extension. Our KVP will be set at 80 to 85. Our mass will be at 80 to 95. And we're going to center at the lower costal margin, about 1.5 inches above iliac crest. For last but not least, we have our L5S1, KVP at 85 to 90, our mass at 100 to 105, and we're going to angle our central ray at 5 to 8 degrees caudad. We're going to center 1.5 inches inferior to the iliac crest and 2 inches posterior to ASIS. Our lumbar anatomy, we have our lumbar bodies, intervertebral joints, spinous and transverse processes, SI joints, and sacrum. They all are labeled in this drawing, and you can see them very well. So I marked them all good. Our AP lumbar positioning, we don't have any rotation indicated by the SI joints, are equal from the center of the spinous processes. Our intervertebral joint spaces are open throughout here from our L1 all the way down to our 5. And the only thing that I said was not very good in here was the collimation. Our collimation could have been a little tighter in through here, and I mean we almost got symphysis pubis, so it's a little much. And our centering is the center, like the level of the iliac crest. I guess if we went to here, we'd be pretty close, so it's not that far off. Our exposure factors, I mean, if you're looking, there's a lot going on here. And I think that our exposure may be pretty close. I mean, we can see everything that we need to see in this anatomy right here. But it's might be a little too extreme. It's starting to wash out some of our transverse processes in here a little bit. So I put that it really wasn't met. Um, the trabecular markings in here, you'll see when we do the comparison, it could have been a lot better, and it doesn't have any motion. We have all the anatomy that we can see. We can see our T12 all the way down to our S1, S2 region, our SI joints, and our intervertebral spaces, along with the spinous process. But when we compare the contrast and definition between one and the other, there's a lot going on. I mean, you can see the psoas muscles and some of the other anatomy that really isn't needed. Also, I mean, we're almost down to symphysis pubis. Like I said, it could have been collimated a lot better to get a little bit better definition like we have on the left side. Now for our oblique lumbar, there's only really one criteria for our anatomy, and that is to see the zygapophyseal joints. I put no because at the top we're kind of missing on that L1. We're kind of missing the zygapophyseal joints even in L2, L1, L2 area here. So they're not completely seen all the way up and down, both the left and the right. So I put denied. So when we're looking at our oblique lumbar, our centering should be at the level of L3. And we're pretty close right here, but it's not correctly centered, like centered with the vertebrae. Here, it's almost centered as if it's like a AP. Um, it should be way up here, and we're actually missing a little bit of the T12, but that's the top, like the whole vertebrae, we can't really see. Coming down, I mean, as far as left and right, it could have been centered a little bit more over on this side and this side as well. Um, 45-degree rotation, it's not really 45 because this is 45, but up by the shoulders and going superiorly up the vertebrae. The shoulders are rotated one way or another, so you can't really see, and that's why we're missing part of the little eyes of the Scotty dog. I mean, they are there, but they're not looking the way they should. The collimation field side, we already said, so that's why I said no to all of this. So for our oblique lumbar exposure, we talked about this in the other um, previous projection. Our exposure factors really aren't that great, and a lot of it is because of the collimation. So I mean, yes, we can see it's all right, but it could be a lot better. I believe if it would have been centered and the collimated correctly, and probably the exposure factors, KVP and mass, probably set down just a step, I think it probably would have turned out looking a lot better. But I did give it a plus for no motion. So on our comparison, I mean, you can see our L2, our L1, our L2, you can see that we can still see the zygapophyseal joints, but when we start getting into here, they're just kind of because of that tilt that we have with the shoulders compared to the pelvis, we're missing it on both sides. So it was probably the patient and due to pain. You'll see it later here when we go to the laterals. Otherwise, all pertinent anatomy is seen. So I would just say the exposure factors could be better and collimation between these two. Lateral lumbar evaluation for all the anatomies. We got our one through all the way to our L5S1 right here. Um, we can see in the intervertebral joints right here. In between, we got all the intervertebral foramina right here. So everything is on there, and the entire sacrum is included down to the coccyx. So that's quite a bit, along with all our spinous processes are seen in a row all the way up until we get to L5. It's a little hard to see. Our positioning for lumbar, we have our spinal column is parallel with the IR, and all the vertebral foramina are open. It's a little hard to see here, but it's due to this vertebrae right here being pushed anteriorly. No rotation. I would say yes, rotation. We got our greater sciatic notch here and here, and they're not even lined up. You can see the acetabulum in this. So the right side of the patient is tilted posteriorly, rotated posteriorly. It's probably due to the pain they're in, and also the collimation. I mean, we only need the like 2 inches from crest, and we have all the way down to acetabulum. So that's a little much. I marked that no go. So our exposure factors. I mean, we got a lot on in the abdomen, and we just turned it up to a 10 with our technique. So it is definitely not good. We have too much technique, probably had to bump the KV and the mass down at least a step or two so we can get a good exposure factor. Also, with our collimation, that probably had a lot to do with it also. So the first two here, no, and there's no motion. And like I said before, we have this whole beautiful lumbar on the left. You can see our pedicles, our intervertebral foramina, everything here, even our articular process of the L5 and S1. Here, you're not going to see that with the pathology. We got pretty good, like all the anatomy that we needed to see for a lateral lumbar is here. It's just the contrast detail, our resolution sucks. So if, like I said before, it just has to be bumped down a little bit, and a lot of it is because of the collimation and what we have going on in the abdomen. Our L5S1 anatomy, we have everything except for our collimation. Our collimation, we got the acetabulum in there. We only need about like this. We have the L5 vertebral body, the first and second sacral segments, and the L5S1 joint space, which should be here, but it's down here now. So on this, we have rotation. You can see it with a greater sciatic notch here and here. They're not lined up. Also with the acetabulums here and here, not really matching either. So as far as being alignment, correct alignment, it didn't happen on this. Our collimation should be right in this area, and it's like a mondo. Also, our centering from here to here. It should be an inch and a half inferior to the iliac crest. We have crest here, so our centering should be like right in here somewhere. We're way off. Our exposure factors, they're not that great. It's kind of hard to see. It's because we're taking a picture of all this instead of here. Our technique and collimation and our centering is way off on this one, but we don't have any motion. So when we look at the one on the left, we see a coned in image of all pertinent anatomy that we needed. And um, we, like I said before, it just needed to be coned in and focused in this area right here. All right, on the radiology report, we have a 14-year-old female with bilateral spondylolysis. There's no comparisons. The findings are 5 non-rib bearing lumbar type vertebral bodies noted. There's a mild height loss affecting the L5 vertebral body. Otherwise, vertebral body heights are maintained. Bilateral pars defects at L5 yielding age indeterminate. Complete anterior dislocation of vertebral body of L5 over S1. Our impression is bilateral pars defect at L5 yielding age indeterminate complete anterior dislocation of the vertebral body over L5S1, likelihood of associated compression deformity of the vertebral body of L5. Soft tissue detail limited by radiographs, however, spinal cord compression is a possibility. No findings of dynamic instability on flexion and extension views. The definition of spondylolysis is the dissolution of a vertebrae, such as from aplasia, lack of development of a vertebral arch, and separation of the pars interarticularis of the vertebrae. Common systems most common at L4, L5, the pain radiates from the lower back to the thigh. Diagnosis typically diagnosed with a physical exam and diagnostic x-ray, usually x-rays, MRI, or CT. Prognosis recovery can take from a few weeks to a few months and are able to resume physical activity. Treatment, the minor symptoms are treated with rest, NSAID, corticosteroids. Severe cases could require surgery to fuse the vertebrae together, followed by physical therapy, and a back brace may be used for stability. The radiographic appearance is usually seen on the obliques. It's seen on the obliques and the neck of the Scotty dog appears broken. the radiology report. These are the standing, flexion and extension. Both of them, they look pretty much the same. There's not really anything different than pretty much the lateral. That's why I didn't really put them in there as part of the studies. I just did it at the end. Here in the CT, they're actually able to see from the posterior side of the sacrum all the way to the posterior side of the L5 vertebrae, the actual distance there, and measure it using CT. And then these are from post operation. These are x-rays. Ended up getting everything um, fused back together, and she ended up getting 11 screws in her back. These are the references that I used, and have a great day.